Dear fourth year students, welcome to this tutorial, Management of Neutropenic Fever, and I hope you will enjoy this tutorial. The objectives of this tutorial: by the end of this tutorial, the students should be able to 1. Define neutropenia, 2. List the common causes of neutropenia, 3. List the common infections that affect neutropenic patients, 4. Outline briefly the investigations of neutropenic fever, and 5. Outline briefly the lines of management. Now we come to the case presentation. A 20-year-old male with aplastic anemia came to the emergency unit complaining of fever of 3 days duration. He is suffering from increasing easy fatigability and pallor for the last 3 weeks. Physical examination revealed a temperature of 39.5, pulse rate of 100 beats per minute, respiratory rate of 21 per minute, and blood pressure of 100 over 60 millimeters of mercury. He was pale and looks ill. No other findings were found on systemic examination. He brought with him a white blood cell count result, which was 500 per cubic millimeter. The tasks required from you: first, define neutropenia and neutropenic fever and list the common cause of neutropenia. The second task is list the common infections that affect neutropenic patients. 3. Outline briefly the investigations of a patient with a neutropenic fever. And 4. Outline briefly the lines of management. You will be given 5 minutes to search for the answers, and after that we will continue the tutorial. Okay, so we start with the first task. Neutropenia is defined as absolute neutrophil count, which is less than 1,500 neutrophils per cubic millimeter. When such a patient develops fever, we label the condition as a neutropenic fever. A single oral temperature, which is equal or more than 38.3, or a temperature of equal or more than 38 on 2 occasions, separated by 1 hour, as I said, in a patient with neutropenia. Patients with hematological malignancies, patients on chemotherapy, and aplastic anemia are the target population at risk. Neutropenic fever is a serious problem, and the consequences of absent neutrophils are dramatic. Why? Because these patients are immunocompromised, they are susceptible to infections, and infections progress rapidly in these patients. The susceptibility to infectious diseases in such patients with neutropenia is increased sharply when the neutrophil count fall below 1,000 cells per cubic millimeter. And when it is less than 500, the endogenous microbial flora that is present in the mouth and in the gut is impaired. And when the neutrophil count is less than 200, the inflammatory response of the body is absent. Of course, neutropenia has many causes. Either there's decreased production of neutrophils. The important cause is a drug-induced that occurs after using alkylating agents, cytotoxic drugs, and other chemotherapeutic drugs. Also, it can occur after treatment with antithyroid drugs, sulfa drugs, carbamazepine, and many other drugs. Hematological diseases are a well-known cause of neutropenia, like idiopathic neutropenia, acute leukemia, and aplastic anemia. Also, involvement of bone marrow by tumors or fibrosis can lead to neutropenia. Nutritional deficiencies like vitamin B12 and folate deficiency can result in neutropenia. And overwhelming infections with Salmonella typhi and Brucella and viral infections can result into neutropenia. The other important cause of neutropenia is peripheral destruction of neutrophils. And this is seen in patients with autoimmune disease and patients who have hypersplenism, especially portal hypertension and myelofibrosis and beta thalassemia major. Or sometimes the neutrophils are decreased because of the infection itself in overwhelming bacterial infections, and also in patients with hemodialysis. This is called peripheral pooling. In this diagram, we see that the risk of infection increases with the progression of neutropenia. The more the severe the neutropenia, the more the possibility of developing a bacterial infection. Now we come to the second task. Which microorganisms are likely to cause infection in granulocytopenic patients? Of course, the bacteria are the most important cause of fever in neutropenic patients, and the bacteria come either from the uh, patient, him or herself. These bacteria are present on the skin, in the mouth, and the gastrointestinal tract, or the bacteria will come from outside the body. Uh, Gram-positive cocci, like staphylococci, and especially methicillin-resistant Staphylococcus aureus and Streptococcus pneumoniae are well-known causes of uh, neutropenic fever. Gram-negative bacilli are very important, like E. coli and Pseudomonas aeruginosa and Klebsiella, and Acinetobacter are also very important. We have the gram-positive bacilli like diphtheroids, anaerobes. Fungi also can cause neutropenic fever, especially in patients with neutropenia who are treated with antibiotics. The most important fungi include the Candida and the Aspergillus species. You see that the most common type of bacteria that causes fever in neutropenic patients is the gram-negative microorganism or bacilli, the coliforms and the Klebsiella. The gram-positive bacteria are less, but still the patients who have central venous catheter, they have an increased number of infections by gram-positive cocci. Now we come to the third task. When we face a patient with neutropenia and an attack of fever, it is very important to act quickly because fever in these patients usually indicates infection until proved otherwise. And the first thing that comes to our minds is the bacterial infection. So we need proper history and careful physical exam. We concentrate on sites of cannulas, on the mouth and perianal region and the lungs, looking for evidence of infection. Uh, Blood cultures are very important, and the cultures should be taken as soon as possible. And if the patient is having a CV line, we need to take also culture from the peripheral vein and from this central venous line. We need to check the renal and liver functions, and we send for C-reactive protein. It is increased in patients with bacterial infections. We need to check for cultures from other sites like the urine for culture and sensitivity. The blood picture is very important. We look for the severity of neutropenia. A blood gas analysis is important in cases of septicemia. We need to send for chest X-ray and ultrasound of abdomen. And sometimes, if these are negative, we need to check for CT scan of the chest and the abdomen, especially in critically ill patients. The patients with a neutropenic fever, some of them, we consider them as high-risk patients. What do we mean by high-risk patients? Patients who are critical and in whom there are certain findings indicating that the infection is rather severe and life-threatening. Who are the high-risk patients? They include patients with hematological malignancies like leukemia, lymphoma, and myeloma, patients with uncontrolled solid tumors, patients receiving aggressive chemotherapy, which induces severe neutropenia, patients with significant concomitant medical conditions like cardiac, liver, and lung problems, patients older than 65 years, and patients who are already on antibiotics because of the emergence of resistance. In these patients, we need to act very quickly. Task 4, the treatment of patients with a neutropenic fever. It is an important rule that we don't wait for the results of the culture. Once we take the blood culture or other cultures, we start aggressive antibiotics until we have the results of the cultures, because the blood culture may give results after 24 or 48 hours or longer. So all patients will require immediate antibiotic therapy, and if the patient is critically ill, we use combination of antibiotics so that we cover the microorganisms, because we don't know exactly which microorganism is causing this infection. Of course, all patients will require a fluid replacement to keep the renal function, especially if they cannot take orally. Intensive care admission is needed for patients who have hypertension or shock. Cardiac, renal, and liver functions monitoring is needed because uh, uh, they can affect the choice of antibiotics and further management. Sometimes we use a flow chart for management. Why? Because for each hospital and for each unit, we should have the results of microbiology updated every few months. Why? Because the empirical antibiotic regime that is used before the results of the cultures are back depends on the most prevalent microorganisms present in the world, and then we can modify the antibiotic regime according to the progression of the condition and the results of the culture. But in general, when there's fever and neutropenia, usually we start an anti-gram negative antibiotic like third generation cephalosporins or carpenicillin or meropenem. And we also, during assessment, we label the patient as having hemodynamically unstable or stable. We mean by hemodynamically unstable, as I said, when the patient is having tachycardia, hypotension, and or signs of shock. Patients who do not have hemodynamic instability, we start these patients on. So for patients who are hemodynamically stable, they have no hypotension, no tachycardia, we look if they have risk factors for gram-positive bacteria, like if they have lung infection, which is evident by chest X-ray or a CT scan of the lung, or if they have intravenous catheter, we add vancomycin to the anti-gram negative antibiotic that we gave to start with. Some patients with abdominal infection or soft tissue infection, we may think of anaerobic infection. And in these patients, we may need to give antibiotics that are active against anaerobic bacteria like metronidazole. Okay? And we continue searching for the source of the infection. Patients who are hemodynamically unstable, they have hypotension, tachycardia, or signs of shock, we immediately add anti-gram positive antibiotics and anti-anaerobic antibiotics, because we don't have time to wait for the response or to assess the patient, so that we don't lose time and we continue searching for the source of the infection. For patients who continue to be febrile after 3 to 5 days of starting the antibiotics, and if the culture comes negative, we need to think of fungal infection like Candida or Aspergillus. We have serological test for aspergillosis, the galactomannan test, and we have for the Candida, we have the, sometimes it grows on the blood culture, but in general, in such patients, we add antifungal drug like amphotericin or other antifungal drugs like voriconazole or other new antifungal drugs. And we continue with the antibiotics until we get response of the patient. There are certain important points during the management of these patients. The first line treatment is anti-gram negative antibiotic, and like cefepime, meropenem, imipenem, and tazocine. The vancomycin is not recommended as part of initial therapy, as I said, unless we suspect that there is a gram-positive infection. Patient is having catheter, soft tissue infection, pneumonia, or the patient is hemodynamically unstable. Or we get a positive blood culture with the gram-positive bacteria. Also, the anti-anaerobic antibiotics are not added routinely from the start. They are added if there is abdominal problem or the patient is having necrotizing mucositis or mouth infection or pelvic infection. Antifungals are also not given immediately. They are given if there is no fever after 3 to 5 days of intensive antibiotics. The granulocyte colony stimulating factor is used in patients who developed neutropenia after chemotherapy. It helps to shorten the duration of neutropenia. So in conclusion to this tutorial, neutropenic fever is defined as a temperature of 38.3 with an absolute neutrophil count less than 1,500. High-risk patients are those with cancer who are hemodynamically unstable, the presence of severe neutropenia, elderly people, and patients who have other system involvement. We call it comorbidities. Empirically start a broad-spectrum antibiotics with Pseudomonas anti-gram-negative regime. In hemodynamically stable patients, no need to start anti-gram-positive antibiotics or antifungals. Aggressive searching for the source is required to guide the antibiotic regime, and admission to the intensive care unit is needed for hemodynamically unstable patients. You can have further readings in Davidson Principles and Practice of Medicine, Harrison's Principles of Internal Medicine, and Infectious Disease Society of America guidelines. I hope that you enjoyed this tutorial, and good luck.